So we're going to talk about acute renal failure and chronic kidney disease. First, acute renal failure. The time frame for that is less than 48 hours of onset of symptoms. And the way you would test for that is you would look at the creatinine levels in the serum, and you can have an absolute increase of creatinine of greater than or equal to 0.3 milligrams per deciliter, or a percentage increase of 50%. You would also look at the urine output, and if it's decreased less than 50 milliliters per kilogram per hour for greater than 6 hours, that would be indicative of acute renal failure. You can have pre-renal, renal, and post-renal causes of this, and the top 5 causes are decreased renal perfusion due to some cause in the body. Medications are known for this. Using certain radiological contrast dyes can cause this. Post-operative and also sepsis can cause acute renal failure. In contrast, chronic kidney disease, it's kidney failure greater than or equal to 3 months is a designation with or without kidney damage. And it's measured by a decrease in glomerular filtration rate less than 60 milliliters per minute per 1.73 meters squared. And a main cause of that would be diabetes mellitus, hypertension, and glomerular nephritis. Now we're going to talk about urinary tract obstructions, and a lot of that can be based off of clinically who's presenting and what group. So if you have an elderly male presenting with a urinary tract obstruction, they would have most likely signs of a lower urinary tract obstruction, like obstructive symptoms of weak stream hesitancy, intermittency, or irritative symptoms of frequency, urgency, incontinence, and dysuria. And in elderly men, BPH, or benign prostatic hyperplasia, would be the main cause that you would think of. And you can do a bladder ultrasound if you suspect that to reveal post-void residual urine. If you have a woman presenting, elderly or pregnant or otherwise, you might think that the obstruction would be gynecologically related, like pregnancy, and pelvic malignancies, especially for older women. If you have a child presenting, there are some anatomical variants that can cause urinary tract obstructions, specifically uretero-pelvic junction obstruction and posterior urethral valves can cause UTOs. And you can use a VCUG to view that. The imaging study of choice for urinary tract obstructions would be a longitudinal ultrasound of the kidney, and you can visualize hydronephrosis, which is water on the kidney. And in order to fix that, you could sometimes do a ureteral stent or a nephrostomy tube. For an upper urinary tract obstruction, some of the symptoms would be dull flank pain and radiating to the groin. So we're going to talk about some of the mechanisms that control glomerular filtration rate. And I did another video about the intrinsic mechanisms, the myogenic response, and the tubular glomerular feedback, which are a big part controlled by the juxtaglomerular apparatus. And now we're going to talk a little bit about the extrinsic mechanisms. So again, we already talked about the sympathetic tone that is carried out by norepinephrine and epinephrine, ANP and BNP from the heart. But now we're going to go in a little bit more into prostaglandins and angiotensin too. So like I said, prostaglandins, prostacyclin are more preferentially working on the afferent arteriole because pro is before, so it's the one before the nephron is how I think of it. And they generally dilate vessels. So they're going to dilate the afferent arteriole preferentially, which would increase glomerular filtration rate, increase renal blood flow, and increase pressure into the glomerulus, so increasing the filtration rate. On the other side of the nephron, you have the efferent arteriole, which is preferentially acted on by angiotensin II. And so we have the 2 in angiotensin II, and so that's how I remember that it comes second. It's on the efferent side of the nephron. And that's going to preferentially constrict the efferent arteriole because that increases the glomerular filtration rate if it's tightened on this end, so the fluid is more stagnant you could say, or there's higher pressure. So it increases the pressure in the glomerulus, which will increase the filtration rate. But because there is a constriction, if there's a constriction anywhere here, that will decrease renal blood flow. So there are some medications that we give that affect these two things, notably being NSAIDs, which have a decreased activity of prostaglandin and prostacyclin. So they'll have an opposite effect on the kidney. So for the effects of NSAIDs, you're going to have the opposite of prostaglandin, which usually increases glomerular filtration rate, but NSAIDs will decrease it, which will decrease the pressure and decrease renal blood flow because it's going to constrict this afferent arteriole. So everything will be down. For ACE inhibitors, they're going to do acts over here on angiotensin 2 because they're angiotensin converting enzyme inhibitors. So angiotensin 2 won't be created in the lungs, and therefore it will decrease the effect of ACE2 or angiotensin 2 on the efferent arteriole. So it'll have the opposite effect. So if angiotensin 2 constricts it, ACE inhibitors are going to make it more dilated. So your renal blood flow is going to increase because you're increasing the dilation. But at the same time, you're not slowing down and making the fluid stagnant in the glomerulus. So your filtration rate is going to go down because your pressure goes down there. So that's the effect of ACE inhibitors, and that's the effect of NSAIDs.